I want to start by thanking all of our panelists in the first session for excellent discussion of the research and some of the implications of the research on PMI in terms of helping move effective PMI use forward. Obviously, that touched on many of the topics that we're going to cover in this second panel today. We're going to hear from a diverse set of stakeholders on their perspectives about PMI's future and how they can play a role as well in this effort. And again, we're going to have plenty of time to open this up for comments and discussions discussion with you all about the next steps for PMI. Very pleased to start this discussion with panelists who are joining me at the front of the room today. Mark Boutin is the Executive Vice President and Chief Operating Officer for the National Health Council. Angela Patterson is the Chief Nurse Practitioner Officer at CVS Caremark Minute Clinic. Ronna Hauser is the Vice President of Pharmacy Affairs for the National Community Pharmacists Association. And Kevin Nicholson is Vice President of Public Policy and Regulatory Affairs at the National Association of Chain Drugstores. And finally, Amy Ebel is the Director of Global Regulatory Affairs Labeling for GlaxoSmithKline. We're going to have opening comments from each of them and then open this up again to a broader discussion. I'd welcome you to continue some of the themes that we talked about earlier today. Let me start with Mark.
Thank you, Mark. I appreciate that. I'm going to provide a few comments and challenge the group to think about a few issues moving forward. But first, let me begin by introducing the National Health Council. National Health Council was founded in 1920 as a patient advocacy umbrella organization. We are the trade association for groups like American Cancer Society, American Heart, American Diabetes, and many other patient organizations. We have all health-related organizations in membership that include business and industry, insurance companies, provider organizations, family caregiving groups, that gives us the ability to really look at patient-centric issues through a multi-stakeholder lens, but the governance is controlled by the CEOs of the patient groups. Very pleased to be here, and I was actually at the very first meeting that was convened, and I've been at several along the way. And I first want to say we've come a long ways, but we still have a long ways to go. At the very first meeting, I quoted Stephen Covey. People are probably familiar with the 7 Habits of Highly Successful People. I see a few heads nodding, yeah. He wrote that book, and there's a quote in that book that I think is incredibly relevant, and it had to do with mature communication. Stephen Covey says that good, mature communication is the balance between courage and compassion. The courage to be honest and forthright, but the compassion to understand the impact on the listener. I think that is critical here. The patient community has been saying for a long time that the information we're being provided is of very, very, very limited use. And we have fallen by the wayside of courage. We've had the courage to tell you every single thing that could happen, both good and bad, but we have not had the compassion to understand the impact on the audience. And so what we've been talking about today is moving us forward. The other quote that I have used in similar sessions comes from Jim Collins, who wrote Good to Great. Jim Collins says at times of uncertainty, and he highlights one of the greatest points of uncertainty in anybody's life is when they're diagnosed with a serious life-threatening condition. At times of uncertainty, people don't look to the evidence to make decisions. They look to social norms and cues on what to do. And that's supported by research. And if you think about that for a moment, less than 20% of the audience wants more evidence thrown at them. They want information provided to them that is contextual, that helps them make decisions. Now, we can debate whether or not that's good or bad, but that is the current state of events. We need to look at how we provide information where people are. And I think a lot of the presentations we had earlier really focused in on that. And I think it's really exciting to see how far we've come over the last 4 or 5 years. Again, there's still a lot to be done, but the previous presentations make it very clear that we can make significant progress here. I want to outline 3 things that I think we have to be really clear about moving forward. One is we need to map out our challenges and opportunities and start to build a cohesive strategy so that we all have a shared vision of what we're doing. I have a particular goal that I would like to see as an outcome here, and I think everybody in the room has a set of goals, both short-term and long-term, but I don't think we've actually completely clarified or created a shared concept of what those goals are. We've been talking today about a lot of different tactics that we would like to employ, we'd like to see the FDA employ, we want Brookings to do. But tactics only work if they're applied towards very specific targets and very specific goals. So mapping out a strategy and developing a shared understanding of that will help us move this process forward much more quickly. The second point I want to make, and it was picked up a little bit on the previous panel, is let's standardize, but let's also stratify. In other words, the concept of a one-size-fits-all might move the needle some, might get us to a D+. It's not going to get us to an A. We've got to be very conscious of the need to have the ability to innovate and the need to make this flexible. I think Ruth made the point earlier that the context of the information was critical. Absolutely agree. But so is the context of the audience who's going to receive the information. If you start to think about how you stratify a population, you can begin from somebody who's completely healthy all the way to somebody with a very specific condition. Are we really making a tool for the entire universe of people, or are we trying to make a tool that is useful for the end user who's going to get it? And if you think about a treatment for somebody with Parkinson's, are they newly diagnosed? How far have they progressed with their condition? What is their age? What are some of the social factors that are of particular context for them? What are the desired outcomes that they want? What are the existing treatment and management options? What happens when the different treatments change? What about the availability, effectiveness, safety of those competing options? What other treatments are they seeking, both medicines and non-medicines? Do they even have access to all or some of these treatment options? All of those sorts of things make a difference in the context of the person. That goes above and beyond their health literacy, their cultural beliefs, their religious beliefs, their geographic location. Creates a great deal of challenges. The context of your audience is important. And this brings me back to a point that was made towards the end that I could not agree with more, and that is patient or consumer engagement throughout the process at very specific defined moments, including at the beginning where you start to identify what is the goal of this information. What is it you really want to communicate to this audience? One of my hopes is that we will get to a point of a shared definition of what engagement is. What are the right methods? We heard a few talked about today, in-depth interviews, focus groups, but they can be much more sophisticated, conjoint analysis with surveys, crowdsourcing, any number of activities that could be very, very informative. We need to have some methodology or some guidance on what those methods are so that we can use them in a consistent way. That will lead us to some huge opportunities moving forward to really drive this out into the sector and really make useful information available to the end user. So I'll stop there. Thank you.
Thanks very much, Mark. Angela?
Thank you. In thinking about how best to move forward PMI in support of safe medication therapy and improved patient outcomes, I really drew upon my experience of 26 years as a nurse, as well as the strengths and efforts and work of the 2,500 nurses who I lead in my current organization. In addition to our physician, physician assistant, and pharmacist partners, I believe a key strategy to move PMI forward is to tap into this country's nursing workforce, a profession defined by its commitment to patient education, advocacy, patient-centered care, cultural sensitivity, population health, and certainly a profession voted by patients as one of the most trusted health professionals. Nurses are powered by numbers, 3.1 million nationally, 190,000 of them advanced practice nurses. They have a consistent presence across a number of diverse settings in our country, including hospitals, community-based clinics, rehab centers, schools, businesses, local health departments, patient homes, among the homeless, and now retail settings. Engaging this country's nursing workforce in supporting this effort is a powerful method to educate and support around PMI. Nursing has long since embodied patient safety and improving health outcomes through safe prescribing practices, as exemplified through its work with Joint Commission with national patient safety goals around medication reconciliation at each and every patient encounter to be performed and documented for tracking, as well as some of the work that was conducted earlier this year by the American Nurses Association, the American Nurses Foundation, and the American Nurses Credentialing Center, where earlier this year they adopted medication reconciliation by all nurses at every patient encounter as one of the 5 measures encompassing nursing quality indicators, measures to be measured and used to inform process improvement initiatives within the profession, defining nursing's contributions to increasing health and well-being in our communities. Aligning PMI with this initiative is a synergistic and naturally complementary element of safe medication therapy with the ultimate goal of improving health outcomes within our patients. From the nursing perspective, PMI is evidenced by accurate patient knowledge and engagement in the medication regimen process is a key factor in quality and safe care. Emerging data around the impact of medication errors, for example, on hospital readmissions is an example of that. And as nurses, we've all experienced those patients who arrive in our setting or with a shopping bag full of old medications or who report their medications by the color and size of the pill or the inhaler. The danger is quite clear to us, and supporting medication knowledge and patient involvement in the medication management process is a nursing imperative. How is this best accomplished? I believe making best practice PMI tools readily available through strategies such as discussed earlier, a central repository, embedded in our electronic health records, on mobile devices, for example, are key ways to make them readily available to nurses as they engage in patients in a variety of settings. Linking these tools with nurses' focus on shared decision-making is a terrific way to bring it forward and impactful in the lives of patients. Shared decision-making is an essential component of evidence-based practice and essentially means that a conversation occurs between the provider and patient. The objective is to facilitate the patient in becoming an expert in their healthcare and the knowledge expert in their healthcare. It's a conversation where knowledge, preferences, and experiences are shared, and then the dyad moves into the second phase of the conversation where options and pros and cons are considered within the context of the patient and the patient's value system. It's a process, it's an interaction that leads to enhanced patient knowledge and empowerment. Augmenting this would include the incorporation of nursing strategies to enhance health literacy. Nurses accessing and utilizing standardized medication information tools as part of engaging in the shared decision-making process with patients during all patient encounters are a powerful and supportive strategy for moving PMI forward. Thank you.
Thank you very much, Angela. Rana?
Good morning. Thanks for the opportunity to be here. The National Community Pharmacists Association represents the interests of our nation's 23,000 independently owned community pharmacies. I'll be speaking on their behalf. NCPA has long held the position that consumers need access to up-to-date and accurate information about the risks, benefits, and safe use of their prescription drugs in order to use their medications correctly and make informed decisions about their care. Consumers still to this day receive multiple pieces of paper from the pharmacy with their prescription drugs, containing information that is developed and distributed through various sources, which in some cases is difficult to read and understand and may be duplicative, incomplete, and/or contradictory. Our association has been active in offering feedback and support to the FDA in the creation and use of a single FDA-approved plain language document to replace existing written information distributed by pharmacies. And we joined our pharmacy and patient care partners on the One Document Solution citizens petition filed in 2008, which urged the FDA to issue guidance towards this end. NCPA understands the limitations that FDA has cited regarding FDA review and approval of all PMI prior to distribution and how this may not be feasible given resources and the volume of products requiring PMI. Nonetheless, it remains NCPA's position, as stated in the citizens petition, that FDA approval of PMI is a large factor related to the success of any PMI initiative. NCPA believes it is because of a voluntary system that we are here today discussing how to best meet content and format standards prior to distribution of PMI to patients. Because our members are currently required to distribute FDA-mandated medication guides and PPIs and voluntarily distribute private sector CMI, the current state of too much information being distributed exists. Unless there's a system in place whereby PMI is reviewed and approved by FDA, NCPA has concerns that we may end up here again in several years discussing the same issues. Our members also have concerns that the ultimate reason we are currently distributing technical, long, redundant, and oftentimes conflicting documents is because these documents are often reviewed under the context of trying to thoroughly meet what can be given to the consumer to address all liability concerns. We do not see this practice ending unless the one document solution is approved by the FDA. To that point, NCPA encourages the participation of both brand and generic manufacturers in future public discussions related to PMI. I will next discuss how the FDA can ensure adequate distribution of PMI while minimizing disruption to healthcare delivery processes such as the practice of pharmacy. As strong advocates for the creation and use of the FDA-approved document, which would be universally used and distributed in pharmacies, NCPA urges the use of technology already in place. Pharmacies should be able to work with their pharmacy management system vendors to access and print the document on demand, which in most cases would be a single sheet of paper that is easy to read and understand, complete and concise, and contains embedded access to more detailed information for the patient if they desire. Use of the document will streamline and reduce costs to pharmacies as well as enhance the level of care to consumers. There is not a one-size-fits-all approach in distributing prescription drug information, and patients should be able to review or retrieve FDA-approved information from their physician or pharmacist via email or on a website, to name a few options. In addition, benefit information must be added to written prescription drug information that is delivered to patients. Current information is too risk-heavy and can thwart well-intentioned efforts by pharmacies to ensure patients are adherent to their medication regimens. Regarding technology that can allow pharmacies to print the one document solution, some pharmacies do not operate laser printers, so any efforts to include requirements that the document be in color or contain high-resolution graphics could not be met by pharmacies, nor should pharmacies have to incur additional costs to print such a document. Pharmacy workflow is critical to day-to-day operations, and independent pharmacies must be allowed to work with their pharmacy management system vendors to access the document and print on demand with every prescription. Community pharmacists generally dispense multiple prescriptions per patient at any given time. That's why we stress the need for a succinct document. One page is optimal, but we realize this is not always possible, so the FDA must address the length of PMI and clearly define any circumstances that may warrant more pages. If it becomes the rule rather than the exception that PMI is multiple pages, we will be faced yet again with our current problem, which is too much information being distributed. In conclusion, NCPA supports the FDA's efforts to enhance written prescription drug information distributed to patients. We advocate for an FDA-approved document written by the sponsor and validated by user testing that could be printed at the pharmacy level using technologies that exist today. The template for the document should include embedded access to more detailed information if the patient so chooses. Pharmacies should be able to work with their current vendors to access the one document and print on demand. It should be a useful tool for the pharmacist to use when educating their patients about medications, as combining useful written info with the personal relationships between pharmacists and their patients will ultimately lead to optimal patient care. Thank you.
Thank you very much, Rana. Go to Kevin next.
Thank you. Again, I'm Kevin Nicholson with the National Association of Chain Drugstores. And let me preface my remarks by saying that a lot of my remarks will probably be similar to what you heard Rana comment on, because our associations have worked very closely over the years on this project. In fact, we also were a signatory to the citizens petition that Rana mentioned. So we do have, many of our concerns are aligned. But NACDS represents traditional drugstores and supermarkets and mass merchants with pharmacies. Our members operate over 40,000 pharmacies, and our 125 chain member companies include regional chains with a minimum of 4 stores and national companies. I want to thank Brookings for the opportunity to address you today regarding our perspectives on PMI. As we have heard, patients receive several different types of information developed by different sources that may be duplicative, incomplete, and difficult to read and understand. We agree that the current system is not adequate to ensure that patients receive essential medication information. We are very pleased that FDA continues to move towards the adoption of a single medication information document that is standardized with respect to format and content. The provision of multiple documents containing redundant or even conflicting information creates logistical burdens for pharmacies that complicates effective patient counseling. It would be far more convenient, efficient, and ultimately more effective for pharmacists to counsel patients by providing a single document that could be easily understood and facilitate a conversation concerning the proper use of medication. We believe that the ideal approach, as Rana mentioned, would be for FDA review and approval of the single document PMI prior to distribution. Only this approach could absolutely ensure that all PMI meet FDA standards of accuracy and comprehensibility, and that all the information is properly balanced to communicate risks and benefits. We are deeply concerned that unless FDA reviews and approves PMI, we will not make any real progress. For example, unless FDA can provide manufacturers with liability protections for the information provided in the PMI will likely result being cluttered with information that is unnecessary and superfluous to the patient. Manufacturers will be inclined to include information to shield themselves from potential tort claims. However, we understand that FDA has limited resources, and we don't want those limited resources to act as a barrier to moving forward with the one document solution. So to address concerns about the limited resources, we believe the best overall approach is for FDA to continue to pilot numerous approaches to assess which approach works the best. We ask FDA to continue with pilot programs to test various potential mechanisms for the development of PMI. For the medications that are included in the pilots, manufacturers would develop the PMI and pharmacies would distribute the PMI to the patients. We would hope that FDA would exercise enforcement discretion not to require any other written information be provided to the patients. Some pilots would have FDA approval of the PMI as an element, and others would test other mechanisms to ensure compliance with content and format criteria. The pilots would test frameworks for ensuring patient access to PMI. Patients should have the option of receiving the PMI electronically, via email, through a website, or through an app on their mobile device. Ideally, the electronic information would be accessible by prescribers, pharmacists, and patients. Prescribers would be encouraged to provide the patient's PMI at the point of prescribing. This could be done by paper or electronically. We would hope that this could be harmonized with electronic prescribing systems and electronic health records, so a patient wouldn't necessarily have to receive paper documentation unless they wanted it. For patients with low literacy or visual impairment, we would hope that there would be mechanisms for them as well, such as a toll-free number or other ways of orally providing the communication to the patients. We recommend that FDA prioritize the drugs that are included in the pilot programs. Highest priority should be given to newly approved drugs and those with med guides. Among those with med guides, we would ask that priority be given to class-wide med guides and drugs with high prescribing volumes. Drugs with REMS should also be considered as a well-written as a well-written PMI may obviate the need for more complex REMS. Basically, the goals of the pilot programs should be to assess whether the PMI's content and format meet FDA standards, as well as whether the distribution is adequate. Overall, we don't expect this to be a static process, but rather dynamic and continuously changing as both healthcare providers and consumers adopt new electronic technologies. Consequently, we believe that FDA should plan to conduct pilot programs well into the foreseeable future to ensure that the PMI that we provide keeps pace with the evolving technologies. Overall, the key to success will be for continued collaboration among the agency, manufacturers, pharmacies, prescribers, and consumer groups. Thank you.
Thanks very much, Kevin. And turn to Amy.
Hi there, I'm Amy Ebel, and I work within the labeling department of GlaxoSmithKline, working on prescribing information and both patient labeling. Thank you for the invitation to this meeting to contribute an industry view within this panel. The views I express here are my own personally and are not formally supported by GSK. However, I believe the ideas I'll share today are mostly consistent with the thoughts conveyed previously by pharma and filed to the FDA docket on this topic at the time of the September 2010 meeting. The GSK labeling department was very pleased to be able to participate in the PMI distribution study, for which we converted current patient labeling for one of our products to a one-page leaflet. This study demonstrated the ability to produce one-page PMI for existing products and distribute it effectively in a pharmacy setting. It can be done. I'm pleased that progress continues to be made toward a user-friendly patient leaflet for each prescription drug product. To make this happen, it will be important to use a standardized content and format with assurance of a patient-friendly vocabulary. Clear guidance on content with a patient focus will be needed, with actionable language, with guidance on what not to include being just as important as what to include. This will help industry move from a standard of what might be nice to have to what is essential and useful for the patient. Standardization of format and content will also ensure quality and reduce variability across industry and review divisions. PMI should include information on benefits as well as risks. It would ideally undergo patient testing. It would be ideal to have the NDA BLA holder create it and have it reviewed and approved by FDA. Recognizing the burdens this places on both manufacturers and the agency, clear guidance on appropriate content standardization and expectations are essential to reduce the burden of creation and review and approval. It should be available electronically from a centralized source, for example, DailyMed, so that patients have the option to receive PMI electronically, and it is in the appropriate format to be used downstream by a variety of users. It should be updated rapidly when important safety information becomes available, ideally reviewed and approved when professional labeling changes. FDA could encourage interim movement by approving more abbreviated alternative formats while regulations and guidances are being revised. For example, GSK was pleased to see a short, chunked, 2-page new medication guide format previously used for the opioid class that was just applied to a drug I recently worked on called Tanzium albiglutide, a medicine for diabetes. More precedents such as this could help industry move in that direction. As regulations or guidances may be developed, it would be very helpful to industry to have guidance from FDA on their expectations of the relationship between prescriber and patient labeling. Specifically, how should the content of highlights and Section 17 patient counseling information of the prescribing information relate to the content of a one-page patient leaflet? There should be consistency in thinking between these components. I'm speaking to the choir here that there is much room for improvement in both content and delivery of currently available patient labeling. As a mother of 4 young children, forgive me that my cultural references tend toward popular children's literature, but I can't help thinking that where we are with patient labeling is sort of like that classic Berenstain Bears book, Old Hat, New Hat. If not familiar to you, it contains a rhyming list of all things wrong with each new hat the bear tries on. Too fancy, too frilly, too shiny, too silly, until in the end he goes back to his favorite hat. Current patient medication information is too long, too complicated, too varied, too scary, too crowded, too small. Mine don't rhyme like the book, but the list could go on. Any new format will also be too something. Getting to a new hat may not feel as comfortable as keeping our old hat, but I look forward to a productive discussion today on how we can get to a quality, user-friendly PMI new hat and make it a reality for patients.
All right, Amy, thank you very much for bringing in the Berenstain Bears along with the diverse other perspectives we've heard about this morning. We are going to open this up to a broader discussion. I'd like to, and so I hope you all are thinking of your questions and comments. I'd like to start out by picking up on the discussion of the pilot programs that many of you mentioned, along with some very detailed and specific comments and suggestions for next steps. So my sense from the comments that we heard and also from the research this morning, it was a very positive view of where things are headed and how the pilot efforts have gone and the constructive findings from the research on the pilots. But keeping with the old hat, new hat, and it's as Amy says, always to something. Any problems that you all have seen in some of the recent pilots or developments, or are things generally going in the right direction?
Well, I'll start off. Again, this is Kevin Nicholson with NACDS, and actually, as we were seeing the presentations, I sat next to Rana, and we were commenting about how, we were pleased by the results of the pilots, and pilots seem to be bearing out a lot of the comments that we've been making over the years as to what should be done. So, in a sense, it's sort of giving us credence to what we've been saying all along, that these are the things that need to be done. And I guess my only perhaps not positive comment is we need more pilots. We need to move things along. We've been working on this issue forever, it seems.
Well, you don't want just pilots. I mean, you would like to have a sort of a standard process.
What's that?
You want something that's sort of a standard FDA approved or FDA reviewed process.
That's
not
our
just
idea.
Pilots. Yeah.
Right. Yeah.
I mean, I took from your comments that we're kind of to the stage where we should move beyond pilots, but you'll settle for pilots if that's.
Well, I mean, understanding. I mean, ideally, we would like it to happen as soon as possible, but we recognize the need for pilots to test the different format, content, understandability, etc. I guess we would like to see more pilots happen more quickly, so we can eventually get to our endpoint and start getting the goal of reaching the goal of getting this information in the patient hands. And I guess that's, as far as pilots, we would actually like to see a broad range pilot where pharmacies are providing this information to patients in real life, and and FDA is exercising enforcement discretion that this is, for a pharmacy that's participating in the pilot, that the information that they're providing as part of the pilot is what they need to be providing.
So can I be a little I'm sorry.
Go ahead, Mark, and we'll go back to Amy.
Sorry, I apologize. I want to be a little contrarian. I get to be the patient advocate, so I can be the one who can shake things up a little bit. I disagree with the concept of the pilot. I think we've got enough information to go way beyond the pilot, and I put that out there. I think we are at a point now with the lost opportunity cost where people are not getting the information they need because of the way we're presenting it. That's reprehensible. And we have enough information to move that forward. I think what we need is some guidance from the FDA to give some clarity around what is permissible, how to engage with the end user. How many people here have a smartphone? Put your hands up, yeah. Do you think that they make any changes to this without consulting the end user? Of course not. What we need are standards on how we engage the end user. What are the appropriate methods? Many of these methods have been validated for many other purposes, certainly marketing, social science, political science. We have a president that has been elected twice using these techniques. We know how to do this. What we need to do is give some guidance on how companies can do this, how they can partner with academic centers, how they can partner with patient advocacy organizations, with provider groups, with pharmacists. And let's unleash this. Let's make sure FDA has the authority to control this because we don't want inappropriate things happening. But let's start to do this, and let's allow some innovation to happen out in the environment to really figure out what works best under what circumstances. And let's get the information to a very stratified population that's going to use this in a way that is meaningful for them. I don't think we should simply be relying on pilots. I think we can do better.
Thanks, Amy.
I was going to go back to, I think you had asked about, mine's more on content, you had asked about what might not have come out well in the pilot. Not that it didn't come out well, but just the reality is that we tested 3 drugs. As most people know, once they've tried to take a prescription product and translate it into patient labeling, it's very difficult. There's a whole science to it and an art to it. And I was just thinking that, a one-page solution might not work for all drugs, but having the ideal is optimal. So I kind of used the parallel of when the prescribing information regulations came out for the physician's labeling rule. The highlights regulation says it's a half-page rule. The half-page rule is a regulation that the industry tries to meet, but there are those drugs, we have combination drugs that have 17 warnings and precautions. You can't get a highlights page down to a half page. There's exceptions to the rule, but the ideal is put out as the standard. And I think we need to recognize that some of the drugs that were used in pilots, while they were varied, there were 3, and as we roll it out, it may not always apply to each prescription product.
Yes, good. Just to follow up on this and also pick up on Mark's comment and some of the comments from the earlier session from Sally and others about the importance of effective patient engagement. So whether, I know there are a lot of views that it's time to move beyond pilots, but there also is sort of clear, consistent views that there is more to learn, especially from, as you said, engaging the end users more. So as the pilots continue, as the development of effective PMI implementation goes forward, what are the most important things to test further? I heard additional formats and additional access methods to reach more diverse groups of consumers. I heard the desires to have effective ways of linking in follow-on information to the concise summary information for patients who are interested. Are there other specific points that you all would highlight for next steps of the highest priority for further evidence on how to do PMI effectively, especially from a standpoint of patient engagement?
I would want to just sort of add on to what Mark had said, and I don't disagree with Mark. I mean, if we can do something besides pilots, if it makes sense to go beyond pilots, we certainly are supportive of that. We just want to. We agree with with National Health Council that we need to get this going. And whether it's pilots, whether it's something else, I don't want to be perceived as being limited to pilots, but we are in agreement that it's time to do something for the benefit of patients. And then, Mark, with respect to your specific question, I don't really have any specific advice on what needs to be tested or what needs to be validated. I think we heard from the previous panel a lot about, a lot of information about that, and it's not my area of expertise, so I would defer to those experts. But I would just say that it really is time to get this moving.
So I think there are a lot of methods that have been validated for a number of purposes, and this is really a new application of a lot of validated methods in a new area. So I think we're sometimes afraid of that. When it's a new application, we think it's brand new, and as a result, it's something big and scary. It really isn't as big and scary as I think we try to make it out to be. What I do think we need is a shared definition of what does engagement mean. A lot of people think participation in a clinical trial is engagement. Well, I would argue that is a very passive form of engagement. A lot of people think tapping somebody on the shoulder and asking them what they think is patient engagement. Well, it is, but it's also a very limited form of patient engagement. We have a variety of different methods and techniques, and they all have value depending on their context, whether it's an in-depth interview, focus groups, crowdsourcing, surveys, conjunct analysis, a variety of different methods. I think we also need to identify at which points along the continuum do we want to engage. Because one of the things that I think has been raised, but I want to drive this point home, is we tend to be engaged at the back end. We should be engaged at the front end when you define what is the most important and relevant information for the end user. We should be part of that conversation because a lot of assumptions are made, and in many cases those assumptions are wrong. Test those at the front end. Let's look at the methods for distribution of the information. We could be very, very helpful in defining that. There's a lot of opportunities, but we don't have a shared definition. We have not agreed on what are the right methods for engagement, and at what point along the continuum would you use those methods. That's where I think guidance from the FDA could be extremely helpful. And then we could innovate and really figure out how to do this well. The last point I'll make, and a few of my colleagues here have said this, don't underestimate the need for the information to be distributed through a contextual relationship. Whether it's a nurse practitioner, some other provider, or pharmacist, most people take their information through cues from people they trust. So this information serves as a tool to help us achieve the ultimate outcome, which is the patient understanding the information and making an informed decision based on their own needs. But for the vast majority of people, over 80%, that happens in the context of a relationship. And it should be happening in the context of an informed relationship, not your neighbor down the street who has their own ideas about how you should take your medicines.
So, Rana?
Yeah, I agree, and I agree where that additional information should be that other providers, I think pharmacy, that's my space. I think we can get a standard content and formatted document today. If someone gave us the document, we could work with every vendor in the country to get it into the pharmacies and get it printed out. I mean, it doesn't take that much of a leap to do that once you have the file. So the mechanism's there to do it. It's just setting it up, getting it to us. We print it out, we give it to the patient. I think the points I made about the importance of having embedded places in the document on where to go for more information, having sites where the consumer can get more information, using that type of information for all the other healthcare professionals, the prescriber, the nurses, the consumers that want more information. So you've got to have that portal, that repository that we've talked about today where that other information is included.
Thanks. To open this up to broader discussion with all of you. If you have a comment or question, please raise your hand and wait for a microphone. I see a lot of hands going up, so over there first and then back here to Lee. And be sure to let us know who you are when you make your comment.
My name is Warren Howe, and I'm a mental health advocate, and I also teach in a community college. And I haven't heard anybody direct comments to mental health medication. I'm looking at the word patient there, and from a mental health point of view, I'm thinking of a broader, not just an individual, but family awareness. And I think Mark was going where I think things need to go with mental health. Because no matter how simple the instructions are, if the person's a mental health patient, they may or may not be competent to understand however format it's constructed. And add to that HIPAA confidentiality, the federal law from 1996 that has placed restrictions on what information families can actually receive if there's a confidentiality qualification in there. I know there's a window in HIPAA that allows, but it's so complicated, and the definition of confidentiality is a problem. So I think I made the point. I'd be interested in anyone's opinion on this aspect. Thank you.
Go ahead, Angela.
I absolutely agree with you that there are certainly different levels of patients or healthcare consumers who need PMI. It's not just the person who will be taking the medication, with patients with behavioral health needs, patients who are disabled, or even hospitalized patients. It's the family members who are in the position of needing to have access to PMI and make decisions. One of the things I mentioned, medication reconciliation, and I think about that as a healthcare provider and thinking about that's about being with the patient and reviewing all of the medications that they're on, that they've received from the variety of access points, what they may be on, and look for issues, things like that would lead to hospital readmission. So for example, a patient who just discharged from the hospital, they were on a cholesterol-lowering agent prescribed by their primary care, another one prescribed by their cardiologist, one that they just got from the hospitalist, and the one that's left over in the bottle in their bathroom that they're taking as well, and looking for those situations where patients who don't have sufficient knowledge around medication therapy are taking all four and end up in a serious condition back into the hospital. So how do we also, it's another complex layer, so it's sort of, I see it as sort of the what next of PMI. So then how do we use PMI to help patients understand, especially in our healthcare system, there is fragmentation, there are multiple care providers caring for patients, and how do they navigate the fact that they're getting prescriptions from a number of different sources, and can they, and what does that overall medication therapy package look like, and is it right for them? But I also agree that the other level is supporting families, those folks who are caring for patients taking medications who can't themselves have access to the PMI.
So two quick thoughts. I think your point is absolutely correct, and I think it has to be underscored. For this to work, it's going to be context specific. And the family caregiver is a critical component of that. And looking at the context and allowing us to innovate there is hugely important. This is a perfect distinction between best practice, or a time to use best practice, and a time to innovate. Best practice is when we actually know what the best thing to do in all these different circumstances are. We actually don't. We have good methods to figure out what might be the best practice in a number of different areas, but that requires us to innovate. And I think we have to do a lot more innovation. And mental health, as you know better than I, is pervasive in our culture. It's pervasively undertreated. And for my population, 133 million people with chronic conditions, the vast majority of them have two or more, and a significant proportion of them are suffering from depression or other mental health conditions. So we've got to look at the context of the individual and how we deliver this information. The last point I'll make on HIPAA, I sat on an IOM committee that looked at that several years ago. And I know this is beyond the scope of this group, but the conclusion of the committee was it does not do a good job in protecting privacy, it hinders research, and it hinders access to appropriate care. So there's a lot more that can be done in that area as well.
Lee?
Thank you. Lee Rucker, National Council on Patient Information and Education, and also my own policy firm, Enhance Value. I have 2 quick questions and then 1 comment. In the prototypes that were described earlier today, I'm curious to know if any specialty or biologic medicines were included. We heard that FDA's fictitious product was Rutopia, but I believe that given the challenges that people have with these particular medications that are being utilized much more frequently, that any sort of prototype testing should include a biologic or specialty product. So that was 1 question, if you're aware of that. My second question was, I think what we haven't heard yet is the extent to which some of these new models indeed enhance desired outcomes or enhance and reinforce patient behavior. For example, does an enhanced PMI model promote adherence? Of course, that would be something simple to measure. Does it enhance communication with the prescriber if the patient should be having some problems with their medication? Are they more likely, because they read about it or had conversations about it, are they indeed more likely to alert in a timely fashion their pharmacist or prescriber? Are they more likely to indeed get monitoring tests that may be required because they read about it and remembered? Of course, everything can't just be dependent on this written document, regardless of how it is received or retrieved. But I think that for future evaluations of PMI, we really need to look at some of those other factors, that because the purpose of having the written information, having the oral counseling, is to help people get the most out of their medicines. My general comment was also, as evolving care models are more and more integrating pharmacists, embedding pharmacists, if you will, in part of the care team, I think this also presents a great opportunity to consider the distribution of PMI much closer to the point of prescribing, that there would be pharmacist counseling and review, hands-on review, if you will, of any sort of written PMI at the point, within the clinic, within the medical practice itself, and perhaps removed from the dispensing function, particularly as pharmacists are being included more in the evolving models of care.
Great. Thanks for the comment and questions. Amy, you had a...
Yeah, I was just going to answer real quickly that one of the drugs that was used in PMI was Ventolin, which is an inhaler. So it doesn't replace the instructions for use, which are, of course, more detailed, but it was for respiratory, a specific, a specialized area for an inhaler product. And the other example I mentioned, Tanzium for diabetes, that's a biologic, that's an injectable pen. So it was a little bit complicated. Again, it doesn't replace the instructions for use, which are much more complicated, but I had those 2 examples.
Any other comments from the panel on on either the pilots or the results on influencing outcomes?
Respect to influencing outcome, I think that's really important. That goes back to a comment I made earlier that I don't think we have an agreed upon set of goals or strategy. And I think that's something that perhaps as part of your role, you could be a very great convener for us to actually get to a common place on that. I do want to emphasize that when it comes to issues around adherence, compliance, one of the key components that's forgotten, both in the regulatory space of drug and device development all the way to the delivery of care, is that people with chronic conditions don't use the healthcare system to get their blood work. We use the healthcare system as a tactic to accomplish our aspirations. Our aspirations for living have far more to do with, can I see my child walk down the aisle? Can I work 10 more years before I have to retire? Will the quality of my retirement be good? Will I be able to walk? Those are the sorts of aspirations that are really important. And when you wrap treatment and delivery system issues around that aspiration, compliance and adherence goes up dramatically. But we don't do that. Patients are not equipped to come into the system and say, here's my aspiration. System doesn't ask the patient what their aspiration is. If we're lucky, we provide the best clinical care, but the clinical care may not meet that aspiration. And if it doesn't, they're not going to be compliant and adherent. It's back to the point of why the context is so important with our providers. We have to have that dialogue. We have to wrap care around it. And that care may not be the best clinical care, but it may be the best to help you achieve your aspiration, and you become more compliant and adherent. So this starts in the regulatory space, and it feeds into what the PMI should look like, but this bleeds into the delivery of care as well.
Great comments. Before we move on, any quick comments from the first panel on these questions, or got things covered? Okay, great. Up here? Oh, sorry, this is from the first panel. Go ahead, Lee.
Concerning whether the enhanced designs affect people's behavior. In doing our study, especially with the people on the phone, they were making comments on the side. And this was the drug lisinopril, which these people have been taking oftentimes for years. And they exclaimed, "Oh, I didn't know that. I'm going to show my doctor this." So there are a number of people who spontaneously said that they were going to use this to communicate with their healthcare providers more, and also that their behavior is going to change. They say, I usually throw these away, but I like this one. I'm going to keep it. So they particularly liked our display, our unusual display of side effects. I'm going to cut this out and put it on my wall. So we don't have the evidence that they did do it, but they're spontaneously saying that's what they want to do.
Okay, thanks. Question over
Sorry,
here.
that was Ruth Day.
Thanks, Ruth.
Hi, this is Kathleen O'Connell from Janssen Pharmaceuticals. I'm just wondering if we really see ourselves as being in a unique situation. Is this a sui generis model that we're trying to develop? And maybe just ask the naive question, if we are. How can the experience from other countries where there's a standard unified regulatorily overseen written drug information that's provided as a regular thing to patients, how can that influence the direction that this initiative takes? In terms not only of the utility of the content and the format, the single content and format that's used, but also the impact on the pharmacists, for example, who dispense it at the site of dispensing, or the patient utility. Can we consider the experience in Australia, for example, as to another big pilot that will help inform our efforts?
Yeah, and I was going to ask the FDA too if they could comment on this, because pharmacists aren't currently required or mandated to distribute CMI. They are required to distribute medication guides. So I'm not sure when the manufacturer assessments are due for the class-wide extended release long-acting opiate REMS. I'm not sure when that round of assessments or feedback is due to FDA, but I was just trying to think through what can we learn from that process, because there was a big push to have physicians or nurse practitioners, et cetera, at point of prescribing to hand out that information. There's a big push, to have pharmacies. It's a more standardized approach. There's a simpler med guide for our members to discuss a class-wide issue with their patients. I was just trying to see how we could use that system to perhaps help out in this current environment.
Do you have any sense on how what's been learned from that so far? Any perspectives
on our end, it's a much simplified process. Again, it just makes patient communication and counseling much easier and streamlined.
Mm-hmm. Any other thoughts on the international experience, if any of you all have any familiarity with that?
From an industry perspective, it's just a common practice. It's well known. The industry, most companies have some vendor, some specialist in patient testing that they work with. It's just part of the creation, approval. It's standardized. There's a process already there with lots of experience from it. And as we become a more global kind of companies are becoming more global, we're bringing more of that expertise within the U.S. So it's new to us. We're still learning, but it's growing, and I think it's very good to see these examples, because it does not look that hard to do.
So it's for what I'm hearing is not that, maybe not a high level of familiarity with what's going on in, say, Australia, but at least no real concerns coming from either the required med guide information here in the U.S. or the international or things you may.
I work on global labeling, so I work on labeling for the EU as well as the U.S. It's just it's something that's required. You write it, you get it tested. It's part of the approval. It's.
But from the consumer's perspective, are they getting it? Number one, are they using it?
Yeah, I can't speak to the public aspect, only the creation and approval of it.
I'm just saying this might be an opportunity to learn more.
And you're absolutely, you put your finger on Australia, which has done a lot more work on what is happening once the consumer or patient receive it. And they're getting some positive results. In Europe, you're seeing a huge transition in patient engagement at the front end. And I think we have an opportunity here to emulate some of their best practices that they've done, but also to innovate. I think there's some things we're doing here that are better. But we should be learning across borders, absolutely.
Other comments or questions? Yeah. Okay.
Yeah, Mike Wolf from Northwestern University. I was on the first panel. A couple comments. So one, I agree on the international front that we should be looking at how there are some assurances where there is kind of third-party partnerships to engage in testing and to ensure that the products are viable to the patients that they serve, although it's far more complicated in the EU, and it's lots of challenges still with translation and other things that still have to be worked out. And my understanding with Australia as well is that there's great, much more innovation going on, I think, in some regards, but also, again, nobody's perfected the specific question, which was, are you doing a better job of having direct communication or engaging a clinician in the conversation, in the spoken counseling? I was going to just direct my comment back to also one of the comments that, the questions that Lee asked. And I'm a little bit concerned. I'm very happy this meeting is occurring, but I'm a little bit concerned that we're making this expand a little bit too much to what could be a really great piece of feedback to the FDA into what, one, commend what they're doing, but also that what are we trying to expect from PMI? And I think we have to very clearly articulate what are the outcomes that we have expectations for in creating a new design and imparting it, ensuring that distribution occurs, which is step one, a huge improvement. If you can say that we've increased the fidelity of the current channels, that we are now ensuring patients are getting something, then the next question occurs is, what are they getting? Is it better information? And those outcomes, I think, really should be focused around improved comprehension and looking at work like Ruth has presented today, and our group has also kind of really been focused in on, like, can people access and understand the information and even apply it? Because once you start moving into outcomes that are far more distal, like adherence outcomes and improved clinical benefit, health services utilization and the like, then you start really having so many other factors that are above and beyond PMI that start to come into play. So I would hope that we don't try to, not saying that I don't want to see PMI be able to support improved adverse drug event monitoring, to improve proper medication use, improve doctor-patient communication, all of the pharmacist-patient communication and the like, and even pharmacist-doctor communication. But I hope we don't lose steam over what we're trying to accomplish today.
Further comments on? See a lot of head nodding.
Well, yeah, can I just echo? Yes, I mean, I think what you're saying is what pharmacists, what clinicians, what I think industry everybody would like to have is something that can be used as a tool for a script as a starting point. Like there are many improvements that can probably be made over time, but we got to start somewhere. Is something that facilitates conversation.
Further comments or questions? All right, well, I'd like to thank our panel for an outstanding discussion of where to go next on PMI. Got a lot of issues on the table, and I think a good deal of consensus there, too. Thank you all very much. All right. Before we wrap up, just a few final thoughts. Brian, want to turn back to you for any last comments? Come on up.
stairs are a little shaky there. Thank you, Mark. I want to thank everybody here at the table, everybody who was at the table before, and everybody in the room, as well as those on the webcast, for making today such a success. We can't tell you how much we appreciate hearing all the information from you guys. Really appreciate it a lot. And all the feedback as well to those who respond to the statements that are made and everything else. It really helps bring all the information together. With that being said, a couple of the key points that we heard today. Need for effective patient engagement in the development and moving forward with the initiative. Definitely something that everyone has echoed, I think, across the board. Comprehension, one of the key points brought about today across the board. Everybody discusses that the need for comprehension is there, and that there are so many factors that come into play with comprehension. We heard about several different approaches, all that showed improved comprehension, but different factors were impacted, or different variables were changed and tweaked to get that comprehension level. So just keeping that in mind. Need for flexibility in the use of technology, not only in access and distribution, but also in that patient engagement factor as well. Across the board, that technology continues to change and opens up these windows for different avenues and impacts, and we have to keep that in mind. Need to continue to consider review and approval as part of the process, which we do at this time. And to continue to look at systems in other countries, which is something that we have considered and will continue to consider. And I know, Mike, I appreciate you speaking up because I know you've done a lot of research in that area as well. But overall, once again, thank you for making today such a success and for bringing forth so much information, for bringing forth the studies, for joining us today. And I know it's a holiday weekend. Go USA. Thank you so much again.
Right. Thanks, Brian. You know, it's been nice to see this whole initiative develop over the last few years. There have been a number of public meetings, you all have alluded to that, and a tremendous amount of work done, both as part of these pilots and as part of just a process for broad stakeholder input from both the public sectors and private sectors, a real collaboration to work to improve the effectiveness of PMI. And as you just heard from Brian, a lot of useful discussion today of where to go next, how to build on the substantial amount of evidence that's been developed on how to integrate PMI into the healthcare ecosystem and how to get to better results for patients as a consequence of that. As you heard, FDA's weighing a number of options for moving this initiative forward, and I know they tremendously valued the input here today. And as you heard, one of those options is potential FDA review and approval of PMI documents, as well as some other specific directions for further evidence development on how PMI can be implemented effectively. And we certainly look forward to working with all of you to keep up this momentum, this really important trend to much more effective patient engagement in use of medications. So I want to thank each of our distinguished panelists for their contributions today, both the ones on the stage with me now and the ones who were up here earlier today, and a special thanks to the people who made this event possible. This took a lot of work and commitment from the FDA staff to support the development of this public meeting, including Sharday Arojo, Brian, as you just heard from, Dan Brownstein, and Elizabeth Wather. I also want to thank our staff at Brookings, including Greg Daniel, Morgan Romine, Ahimsa Govinder, Joanna Klatzman, Matt Longo, Michelle Shaljian, and Derek Griffing, who put together a lot of these materials for us. And most of all, I want to thank all of you. This is a collaborative process. Patient engagement and broader engagement does not work without this kind of ongoing engagement. It's a lot of time and efforts. It really is a journey, but thanks to your efforts, we're making a tremendous amount of progress, and we look forward to seeing you at future events as we continue to move forward on PMI implementation. Thank you all very much, and echo Brian, go USA.